It's a real privilege to be here today to talk to. I guess we got family members. We may have some sufferers here. We may have people who have dementia. We may have some students, I understand, who are training to be personal care attendants. I guess we got family members. We got Liz here, researchers. Anybody else that I haven't identified that could be here? Okay, so what is dementia? We hear about dementia. Dementia is a group of conditions. So when we say dementia, what kind of group of conditions are you talking about? Well, conditions that obviously affect cognition. But more than affecting cognition, they also have functional problems associated with them. So diagnosis of dementia is one that involves cognitive impairment plus functional loss. When we talk about cognitive impairment, what are we saying cognitive impairment? Because cognition has a whole lot of different parameters around it. We've got memory, we've got speech, we've got language, we've got calculation, we've got personality, we've got a thing called executive function where we plan things, we don't have to think about planning things. We have attention, we have concentration. So I just rattled off about 8 or 9 fields of cognition. What about function? Well, when we talk about function, people with a nursing background would probably say ADLs and IADLs. What does that mean? Well, ADLs are activities of daily living. That's the things you do to keep yourself personally, hygiene, wash your face, wipe your bum, personal care things. IADLs are things that keep you in society. Your ability to answer the phone, your ability to pay your bills, your ability to drive a car and get around, shopping. Shopping is a great idea. Okay, women love ideas. Some men don't. So when we think about dementia, we think about a condition that affects cognition, but also affects function. It has an impact on function. So a person can be forgetful, but if they're smart enough to keep their memory pads around, and they can do everything normally, then we really can't say they're suffering from dementia. They could have dementia though, because we know that people who are forgetful and are really, really forgetful, that may be an indicator of future downstream dementia. Okay? We know that dementia is progressive. We know that it interferes with the day-to-day social function. So, any questions at this point? Okay? Clear as mud? Carry on. Mild cognitive impairment. Well, this is a term that you'll hear used in Canada. It used to be called cognitive impairment, no dementia. That's what doctors would say. Mild cognitive impairment now is the buzzword. These fellows have written books on this stuff, right? Mild cognitive impairment is a condition where people are forgetful. And the forgetfulness goes beyond what we would call a normal forgetfulness. A normal forgetfulness could be, well, what did you have for breakfast this morning? That's a normal forgetfulness. Okay? After a while, you think about it, you jog your memory. But people who have mild cognitive impairment are more forgetful than that. They're going around all day long to forget things. So all of us at times will forget things, but usually we know that we've forgotten it. People who have serious memory disorders can't even remember that they forgot it. Okay? So mild cognitive impairment, where people are really forgetful, these are the people that are writing notes down, writing things on their hand all the time because they've already learned that they're so forgetful that they had to make an accommodation to meet that memory problem. So, if you got mild cognitive impairment, is that serious or not? Well, the Canada Health and Aging study is a study that was, the principal investigator is a Newfoundlander, Dr. Ken Rockwood. And Ken, this young lady had the good privilege to work with Ken for about 5 years, I understand, as a research assistant. So she's got wonderful training. And Ken is one of those people who, brilliant people, figure out real simple things that nobody else can see. And one of the things Ken figured out was that people with dementia lose their scheduler. when you came here today, you didn't have to remember that you had 3 o'clock, I'm going down to the Alzheimer's Society, I got this morning. You didn't have to worry about brushing your teeth because that came automatically. You didn't have to worry about what you're going to have for breakfast. You went to work. But 3 o'clock you were coming here, and then after here you're going home, you have supper, and then you're probably going to go out to dinner. You don't have to think about that. That's in there automatically. But people with dementia, that gets all mixed up. And Ken was one of the first people to describe that, Newfoundland. So anyway, mild cognitive impairment. What is it? It's a general term most commonly used to describe a subtle but measurable memory disorder. Memory problems greater than normal for that person's age. Okay? Does not show other symptoms of dementia such as impaired judgment or reasoning. Okay? So, we got a person who's forgetful, but they're really forgetful. Now, the Canada Health and Aging study was a study that was started in 1994. And they took a cohort of over 10,000 Canadians, and they had them in 3 streams: well, forgetful, and demented. And the forgetful ones were what we were coining then as mild cognitive impairment. When we followed that cohort of people, what we found was something quite dramatic. That about every year, 10 to 15% of these people convert to dementia. So that if you follow that course of people over 10 years, fully 80% of people with this disorder will have dementia. Now, just to keep you humble, as medicine, and I'm a doctor, we like to keep humble because we're never that smart that we can predict things before they happen. And there's still a small bunch of people who don't behave that way. They can go on like this for the rest of their lives. They'll never become demented, but there's a small number. And sometimes it's accelerated, sometimes it's not. And you'll find that when we talk about dementia, even though there's a syndrome, and we can tell you what the syndrome looks like over time, the rates are different for different people. And that's important to realize. Okay, online, are you okay with that so far? Any questions? Are we good?
We're good.
Okay. Types of irreversible dementia. So dementia is this big bucket with memory problems which affect function. It's the big bucket. And in that bucket there's about 100 different diagnoses. The most common diagnosis is Alzheimer's disease. And Alzheimer's disease has some particular neuropathological findings which we can find at autopsy. And now there's a little bit of work being done now in PET scanning, and where they can actually tag the amyloid plaque, that we can actually see it in real time. So Alzheimer's disease, probably 55 to 65% of all dementias have the neuropathological findings of Alzheimer's disease. It's the most common form of dementia. Okay? Then vascular dementia, we think, is probably about 20%. But if you were to go neuropathologically, vascular dementia and Alzheimer's overlap. So you'll see people with what we think is vascular dementia, but when you do the autopsy, you find they have findings of Alzheimer's disease. And similarly, people we think that have Alzheimer's disease, we do the autopsy and we find strokes and stuff like that. So now, in this day and age, with MRI technology and with CAT scanners, we know as doctors, gee, we get these people and they've got microstrokes and they don't have any dementia. But are they at high risk for downstream things? Well, that's the future. We're gonna find that one out. But we do know that these two conditions overlap. And the mixed dementia is probably going to turn out in the future to be one of the most common forms. Whereas now, at the stage of where we are now, Alzheimer's is number 1. Number 2 would be still mixed dementia. I think vascular would come behind that. Pure vascular dementia, by the way, is a rare entity. There was one neuropathological study done, and I think on over 2,000 postmortems, there was about 4 patients who were truly vascular dementia and nothing else. So vascular dementia itself, pure vascular dementia, must have more going on, and pure Alzheimer's must have more going on. So the two conditions probably are linked somewhere along the way. So that's the researcher. We'll have a great argument and a great discussion with you on that. So let's go on a little bit further now. Types of irreversible dementia. Lewy body. This is still in this group. Lewy body composes about 10% of dementias. By the way, on the slide before, 80% of all the dementias out there are those 3 conditions. 10% about Lewy body. Frontotemporal, pure frontotemporal is probably about 1%. But frontotemporal dementia will affect about 10% of dementias, because the frontotemporal symptoms can present in Alzheimer's, it can present in vascular dementias, and it can present in mixed dementias, because these dementias affect other lobes in the brain. But the particular type of dementia that just affects the frontal lobes is called Pick's disease, and primary progressive aphasia is another one of those. And these are people, the primary progressive aphasia people are people who get speech contraction. They lose their big words, they speak with smaller words, they have problems naming things. It's a language-specific disorder. But what's really fascinating about primary progressive aphasia, they go one of two ways. They either keep on and become neurodegenerative and become very frontal in their approach. In frontal dementias, they lose their the natural inhibitions that we have, that the frontal lobes give us. So they tend to be loud, they tend to be bizarre, they could be taking their clothes off in public, which hopefully I will not be doing today. They'll be doing all sorts of things that are really weird. And you say, they tend to perseverate. They say things over and over and over again. Or they get into habitual habits, right? Repetitive things. They tend to be emotionally difficult to deal with because they lose their filter. So if you have a person that's grieving, they could be totally flat affect, or vice versa. They could be angry. So they're very, very difficult in terms of how to deal with, but they're very easy to identify, generally speaking. And the other way the primary progressive aphasia goes, they go completely into Alzheimer's. So they follow an Alzheimer's pattern. So that's just one of those things we know. Pick's disease was one we used to think years ago was this selectively, because you could see it on neuroimaging, where the frontal lobes would atrophy quicker. And we used to talk about personality being affected and perseveration, and there was a whole bunch of P's, and I forget half of them now. But that's how we used to remember these things in medical school. Right now, we know that this disease, this area of dementia and the differential diagnosis is rapidly expanding. AIDS dementia. This is an infectious disease dementia. It's a viral dementia. It affects all the lobes. Korsakov's is the alcohol-related dementia, and this is a peculiar one in that in the advanced stages, people confabulate. They make up stories, but the problem is, to them, the made-up story is real. So you might know, if you lived with them for a long period of time, this can't be real, but they will actually believe it. Did a lie detector on them. The fictitious story that they're telling you, they will pass the lie detector every time. So it's, so these are, and drug-related is another one. Frontotemporal dementia involves the frontal and usually the temporal lobes in the brain. Occurs most frequently between the age of 55 and 65. These are earlier dementias. The first, indifference, la balle indifference. Impulsiveness, insensitivity, loss of insight into actions and decisions. Okay? It's a rarer form, but very visible. These people don't hide in society too well. They're identified readily. They're the one the neighbor says, there's something really weird going on here. Right? They don't get away.